Hi, welcome to another episode of No Dementia Podcast, where we talk about dementia, but also about improving brain health. I'm your host, Joe Tumalo. I'm a volunteer here at Dementia Society of America. Our mission is to enhance the quality of life for those living with dementia, their caregivers, and the community. To know dementia, we have to have good brain health and live a beautiful life regardless of what comes our way. I'm really excited to have our guest today, Dr. William Chou from Passage Bio, super smart physician and researcher working on gene therapy for people with frontotemporal dementia, knows how to take something that could be very complicated and technical and make it very simple for us to understand. So I think you're really going to get a lot out of this one and enjoy it. Okay, before we start, quick important message. All content, including any potential medical information, is provided as an informational resource only and not to be used or relied on for any diagnostic or treatment process. It should not be used as a substitute for professional diagnosis, care, or treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. The opinions expressed and the content shared by me and my guests today are not necessarily the opinions or content of the Dementia Society of America. Enjoy. Welcome, my guest, Dr. Chou from Passage Bio. Dr. Chou, thank you for being here.
So happy to be here. Thanks for having me.
Awesome. A fellow Philly guy. So
absolutely. Fellow Philly, and with Passage Bio, back home most of the time, most of the week back home in Philly.
Awesome. And can you help us understand Passage Bio and the value that you bring to?
Sure, absolutely. So Passage Bio, we are a gene therapy company that's focused on CNS disease. And one of the programs that we have is for frontotemporal dementia, a very specific type of dementia. So we're excited. I mean, the people join and do biotech and do pharma so that we can make an impact on patients. And I've been privileged enough to work in gene therapies really for the last 8 years or so. And so this is the first time I've worked in CNS gene therapies, but I've seen their impact in other areas of disease, from cancer to sickle cell disease, and it's pretty profound. So it's quite an honor to be working in gene therapy in this area.
And can you help us understand CNS?
Sure. That's central nervous system. So we work on central nervous system disorders. So we have a program, as I mentioned, for frontotemporal dementia. We also have a program for GM1 gangliosidosis, which is a rare disease of newborns. Yeah, and both of them affect the brain and the central nervous system.
The brain, which is why we're here today talking about brain health. So, question: is dementia a disease?
Yeah. So that's so funny you asked that question. So I was just texting with my daughter who was in college, and so we were away on vacation, and she's taking a class right now in bioethics, and she texted me. She said, "Hey, look what my prompt was for this assignment." It was pretty much that exact question. Let me get the wording right. The question was, is dementia a special case of aging, or on a continuum with how we should think about human life generally? And so that was a prompt. She's like, "Dad, I'm doing the reading myself, and I'm curious what you think." And I said, "Well, I actually have a lot of opinions on this. This is what I do. I actually trained as a geriatrician so I'm a physician by training, and I trained in geriatrics before. So I've taken care of a lot of patients with dementia." So my answer to her is, it is indeed a special case of aging from my point of view. I don't think we should think about dementia as a spectrum of normal aging at all, for a few reasons. One, there's the majority of people age without getting signs of dementia. The second is that dementia is a very broad term, and there's so many different specific pathophysiologies of dementia that are very discrete. They for people get memory problems, or what we would call in general dementia, in many different ways. And that leads to the third thing, which is because there's so many different mechanisms of dementia, as drug developers, we can develop treatments that target specific mechanisms of dementia. And that's one of the things that we're doing here at Passage Bio. And that's why it's kind of an exciting time to be involved in dementia, because there are so many treatments that are coming available.
And how recently have there been treatments coming?
Well, there have been treatments for dementia. So when I trained in geriatrics, we had treatments for dementia. We used medicines like Exelon and Aricept and Namenda, and these were great treatments, but there was a long time where there were many failures for new treatments, and it was a little discouraging to be in Alzheimer's research. And now we've got a couple of newly approved products that really show tremendous benefit for patients with Alzheimer's dementia, and we've got more products that are soon to be approved. And so it's an exciting time, because success begets more success. So when you have therapies that can make a big impact on patients, more people are interested in joining the trials. There's more research that is done, because you need to see these successes. And we've kind of had a little bit of a gap in terms of successes for dementia research. And now we're seeing some of these successes. So honestly, it's a pretty exciting time. And I think, if I think back to when I was in training, there was just fewer treatments available. And so the mentality was, yes, we can start you on some medication, but there is a lot of attention that we need to provide to the whole psychosocial support network that is needed for patients and their families. And while still that is incredibly important, we need to spend a lot of time on the psychosocial support. With more opportunities to have actual drugs and treatments, it allows all physicians who are treating patients with dementia to take a little bit more of an aggressive approach to say, hey, there's several different options that we need to consider. Can we make the diagnosis earlier? Can we intervene earlier? We have options available. And so that's all really exciting for the field of dementia.
And are you treating the symptoms? Like, is it appropriate or accurate to say there's no cure necessarily, but we're trying to minimize the symptoms?
Yeah, so I think that is very appropriate to say that right now. There is no cure right now. All of our treatments are looking to really slow down the process and to slow down any decline as much as possible. It's exciting that some of the newly approved treatments are really catching patients earlier. And so can we catch patients as early as possible and intervene as early as possible to really stave off that decline? Now, what I will say is science is a process, right? We chip away at it step by step. And so this is the first part of the process. And ultimately, we'd like to get even further where we could potentially even reverse changes, but we're not there yet. But like I said before, it's a process, and we have to make slow and steady progress along the way.
I'm trying to think of how to phrase this question, but is there a percentage of, or like a typical timeline of how long it takes the average person with dementia to be diagnosed? I guess it depends on, like, we have a family friend who was just diagnosed with Lewy body disease. He's young, he's in his 60s.
Right.
It's heartbreaking. But, even like 2 years ago, my brother and I are friends, and we both had conversations with him. We were like, there's something going on. And, his wife, somebody said his wife was in denial. So I guess a lot of it has to do, because I would assume the person, if I had it, I probably wouldn't necessarily be aware that something's happening. But if my wife, maybe it depends on the caregiver, the partner, spouse, of how willing they are to accept that maybe there is something going on versus ignoring it.
Absolutely. It really does. A lot of times the patient themselves is not aware of the changes that are happening. So you're depending on loved ones. And it comes back to that first question you asked me, is this a normal thing that I should just consider this normal? Or is this or are these changes something that I need to go see a doctor with because there's a potential treatment, there's potential things that we could do. And as we develop more treatments, we need to get the word out as much as possible to patients and their families that you should not accept these changes as normal. And you need to go and look for intervention as soon as possible because there's treatments that we can offer. And the earlier you get them, the better. And so you shouldn't sit on things at all. I mean, you think about, I'm thinking about an example like, for instance, early mammography or breast self-exam, right? These are things that if you catch a cancer early, there's so much more you can do with it. And so everybody has that ingrained right now, right? Because we've done a really good job as physicians and society saying you need to detect cancer early so we can make an intervention. Well, dementia is becoming the same way as we develop more therapies for it, which is we've got to make people aware so they can find out early so we can intervene early.
And what are, as far as the symptoms that you're helping to slow down the progression of, are there, like, can you give us an example of some of the symptoms that are like really would be obvious to the person dealing with it and the caretakers?
Sure, absolutely. So now, like I said before, Alzheimer's dementia is the most prevalent kind of dementia. There's more than 4 million people in the US who have Alzheimer's dementia, and that's going to be memory loss. So that's just being forgetful, and that's kind of what you think about in general when you think about dementia. But what is critical is there are multiple types of dementia, and there are some more rare forms. So the form that we treat is called frontotemporal dementia. It's the type of dementia that you might have heard Bruce Willis's family just announce that he has. It's more rare. There's only about 50 to 60,000 patients in the US with it. It usually strikes patients who are a little younger. So you mentioned your friend with Lewy body disease who was younger. Frontotemporal is similar. It's about 45 to 65. So the key symptoms for frontotemporal dementia that you would look for are first behavioral changes. So we hear about patients who have personality changes. They are a little more disinhibited. They have some more compulsive behaviors, and they get something that is disturbing to family members often. It's sometimes a loss of empathy. And so if you notice that your loved one has had a real change in their personality and who they are, that may be a sign of something like frontotemporal dementia. The other type of symptom we look for FTD is language difficulty. So problems finding words or problems articulating words. And it's really important to spread the word and to have awareness of this because the diagnosis is a clinical one. And even physicians, not all physicians may be trained in these patterns. So it may take a neurologist or a psychiatrist or a geriatrician or someone who is familiar with this specific type of dementia to make that diagnosis.
And so what are the treatments that you're working on? So what would be some of the symptoms that they are, like I said, slowing down? Or
it would be slowing down all of those symptoms. So yes, the goal is to slow down all of those symptoms. And for frontotemporal dementia in particular, and also many different dementias, it's the kind that we treat. So we treat frontotemporal dementia for patients who have a very specific genetic mutation. It's called the granulin mutation. And so patients are missing functional copies of this gene, so they don't make enough of a specific protein called progranulin. And so they have very low levels of progranulin in their brain. And so our gene therapy replaces and gives them a functional gene. And so they get very high levels of the missing protein called progranulin. And the key thing here is that to qualify for, and we are not the only ones studying this. There's a lot of research, very active research in this area of dementia, of these genetically derived dementias. To qualify for this kind of treatment, you not only need to be diagnosed, which we talked about, all the awareness that is needed to be diagnosed, but patients also need to be genetically tested so that we see that they have this gene, because we have a very good way to replace this missing enzyme. And there's other therapeutic options that can replace this missing enzyme. So it's important not only for patients to get diagnosed, but they also need to get genetically tested. And the reason is we can intervene. If it turns out that they are positive for this specific genetic mutation, we can intervene. In many ways, this is how other areas of science have also developed. So if you think about, I'm going to use cancer treatment again. So if you look back 40 years ago, there were not a lot of options for cancer treatment. But as the science caught up, there are more and more therapeutic options available. And actually, if you go to any oncologist, most cancers are genetically tested to see, is there a specific gene that you have that might match up with a specific therapy? Okay, so that's the modern way of treating cancer. And it certainly wasn't like that 30 years ago. So the field of dementia, we're not there yet, but we are getting to that place where dementias, there is a reason to genetically test people now with dementias, because so many therapies are being developed for specific genetic mutations. And people just need to get involved, and physicians need to be aware of this as well. So that's part of what we're trying to do.
Educating physicians? Educating
physicians, educating family members of patients with FTD.
And how do you do that?
As many ways as possible. So we do a lot of talking with patient organizations like yourself. With physicians, we have multimedia ways of trying to educate physicians. We do it online, we do it in person, there's medical talks. I think the biggest thing for educating physicians is physicians need to know that there is a reason to do something. So when I was in training, we wouldn't genetically test dementias because there wasn't anything you could do with the results. And so once a doctor knows that there is something you can do with a test result, they're much more likely to get that test. And so it's important for us to just get the word out there that there's treatment options available for patients who actually test positive with the genetic mutation.
Can any of us that has no symptoms, if we want to, I don't know if I would want to know, but are there some of that testing that could be, or maybe they're doing it now, that would say what's the likelihood that I would develop dementia at some point?
Yeah, it's not something we would recommend for. So the type of tests that we do are for very specific mutations that are associated with frontotemporal dementia. And we would not recommend them for the general population. The people who should get them are people who actually have the diagnosis of frontotemporal dementia, or family members of patients with frontotemporal dementia who may have tested positive for a mutation. And the reason it's important is if you know you have a family member who has this mutation, knowing is important for you because you could potentially qualify for other studies down the line to catch this earlier, to catch the disease before any symptoms occur. And so those are the two types of people who we would think would be important. And for we and others who sponsor these trials offer free testing for these specific genetic variants.
And you have a partnership with the University of Pennsylvania?
University of Pennsylvania is one of our trial sites. So we have trial sites at the University of Pennsylvania, in Houston, in Montreal, Toronto, Brazil, and we'll soon be opening a couple in Europe.
And is there a laboratory somewhere that you have that is actually doing the testing?
Yeah, so yeah, we have a couple of labs that we work with that do the genetic testing. It's pretty simple. It's just a blood draw, and we send the blood draw away. We have a laboratory that actually makes our gene therapy. So making of a gene therapy, it's a living product. It's a drug, it's a treatment, but it's actually something that is I wouldn't call it it's more active than your average pill that you're going to be getting. And so, yes, we have some labs that create this gene therapy for us and that make the gene therapy for us. And then our investigational trial sites, such as the University of Pennsylvania, they administer it.
Wait, to think of, so it's in a pill format?
It's not in a pill. It's an injection.
Injection.
So the way our gene therapy works is it's an injection. It is a one-time therapy. So it's a therapy that a patient would get just once, and it would make this missing protein indefinitely for them. So you don't have to keep coming back and back and back. The way ours is administered is it's like a lumbar puncture, or when women, when giving childbirth, they get an epidural. So it's a needle into the same space as like an epidural or a lumbar puncture, but we do it a little bit closer to the brain so that we can get the medicine all the way into the patient's brain. It's done under CT guidance. So we have a radiologist. They can see everything about where the injection is happening. And so it's done under really accurate, precise methodology. And it takes about 2 minutes. So it's 2 minutes, needles in, you get your infusion, and you're done. And so it's a one-time therapy.
And how long, on average, would it take for that to actually do whatever it's supposed to do?
Yeah, well, so we can start seeing the effects, such as replacement of the missing protein. We could see it pretty fast. In a month, you can see what the levels look like in terms of replacement of the missing protein. So you can see that at a biologic level really quickly. Now, in terms of how quickly you see slowing of dementia symptoms, that takes longer because it's one thing to replace the protein, but then it is a much longer process to having a full effect throughout the brain. So in general, the studies that are done for dementia, they're usually, you look for clinical changes over about 1.5 years. And you compare after 1.5 years, what does it look like? What do patients look like who are not taking this medicine versus who did get the medicine?
I don't know if this is relevant at all, but it just reminds me of like back pain.
Yeah.
Where you can, from what I understand, like I had issues last couple of years, and just working with physical therapists who would say, look, you're training your brain to overreact. So, okay, you had issues with your back when you, whatever, were running or biking.
Right.
And then you're probably training your brain to overreact to something. So part of it is, okay, I'm going to go for a run or a bike ride. I'm not going to freak out. I'm not going to let my brain trigger that. So with this, maybe it's not as, they're not as conscious as what's going on, but are we subconsciously training our brain to act the way we're acting, and then this comes in, and there's a time period where we have to retrain our own brain, or is the gene therapy doing all that work for us? That was a long question.
Yeah, no. I think there's a bit of analogy there that you, I would say the difference. So I understand in physical therapy, when you have an injury, you compensate. run the wrong way and you have to relearn how to run. So I would say for an ailment like frontotemporal dementia with this particular granulin mutation, um, the difference is that you are physiologically missing a protein with this specific type of dementia, whereas with the back injury analogy, you've just taught yourself to run the wrong way. The similarity is that yes, it may take time for both to really correct. These are things that aren't just like an immediate fix. You don't go to physical therapy and immediately you have no pain and walk correctly the next day. Similar when even though we can replace and get levels very high, even above a normal level in the patients who we can treat, it's going to take some time to see those benefits.
Interesting.
Yeah.
Really fascinating. I hate to say enjoyable when we're talking about such things, but enjoyable conversation and hopeful.
It's hopeful, right? It's hopeful. These are very difficult diseases, but it's very hopeful because where we are in this process of scientific advancement, we're in a very good place for the study of dementia. And I think if I could leave people with anything, it's we got to this place because people were willing to get involved in clinical trials and say, you know what, I'll give it a shot because there's not a lot of good treatments available and we need more good treatments. And so for us to be able to continue either in Alzheimer's dementia or in frontotemporal dementia, we need people to be aware and get involved. And that's how science continues to progress.
Awesome. Anything that our listeners can do to help spread the word?
I would say just let's talk about it. Don't be afraid to talk about it with other family members. If you notice something that is happening and something that might not be right, let's not sit on it. Let's have an open discussion about it. And that's why, things like the Willis family coming out and sharing what's been happening with Bruce Willis, it's important because it gives permission for people to have that discussion. It's out there in the public, and even somebody as iconic as Bruce Willis suffers from this. And so I think that is all a step in a great direction.
Wonderful. Anything that you want to promote, endorse as far as a website or resources for people?
Sure. So if people are interested in our study, they can visit us at passagebio.com and you click on our studies. And right there, you can see our study of frontotemporal dementia.
Wonderful. Thank you, Dr. Chou. Really interesting and helpful, and we really appreciate your time and expertise.
Okay, great. Thanks for having me.
Take well. Thank you. Well, thank you for listening. I hope it was helpful. This is a monthly podcast, so check back, please, every month. We'll be bringing you new ideas and information to help you with better health and navigate dementia care. Do you have your umbrella guide yet? This is an awesome, easy to read document, 16-page, filled with facts of understanding dementia, care planning, how doctors can help, and ways to keep your brain as healthy as possible. You can get a free copy by going to 1-800-dementia.org or by calling 1-800-DEMENTIA. We're a national nonprofit. We're here to help you. And please let us know how we can do that. All the best.